Hello everyone, my name's Kevin Fernando. I'm a GP partner at North Berwick Health Centre near Edinburgh and also Scottish lead of the Primary Care Diabetes Society. In this e-learning module, I'm going to talk about the primary care management of chronic kidney disease. We're going to cover some key take-home messages from the recently updated NICE CKD guideline. It was originally updated during August 2021 and again updated during November 2021, particularly focusing around the use of SGLT2 inhibitors for the management of chronic kidney disease. And then a big part of what we're going to discuss today is how we can delay that progression of chronic kidney disease, delay the requirement for renal replacement therapy, either dialysis or renal transplantation, which of course has a significant impact on both quality and quantity of life. And then I'll finish off by talking about some of the new therapeutic options for chronic kidney disease, which I've alluded to already in the form of SGLT2 inhibitors. For 20 years plus now, it's been well established that RAS inhibitors, both ACE inhibitors and ARBs, are the standard of care for those living with CKD. But we now have a new therapeutic option, which really does change the way we approach the management of CKD in primary care. So unfortunately, chronic kidney disease, when your eGFR drops below 60 mils per minute, is not good news. It means that that person is more likely to suffer from cardiovascular disease, be it ischemic heart disease, heart failure, peripheral vascular disease, or cerebrovascular disease. And tragically, they're more likely to die from that cardiovascular disease too. Because of changes in hemodynamics, in pharmacodynamics, it can be more difficult to achieve the tighter blood pressure targets required for many people living with CKD. And again, because of changes in fluid dynamics, individuals living with CKD are more likely to suffer ankle swelling and fluid retention too. Additionally, because of changes in calcium metabolism, there's an increased risk of vitamin D deficiency and increased risk of osteopenia and osteoporosis, and therefore fractures, including hip fractures. And finally, because again of changes in pharmacokinetics and pharmacodynamics and how drugs are transitioned through the body, there's an increased risk of hypoglycemia in people living with CKD. So anything we can do to try and prevent that decline in eGFR, as you can see, is going to have a huge impact on quality and quantity of life. So very much the key message of this e-learning module is protect your kidneys, save your heart. CKD is in essence an independent cardiovascular risk factor. This was actually the slogan from World Kidney Day way back in 2011, over 10 years ago now, but remains very true today as well. So first of all, again, drawing from the updated NICE guideline on CKD, who should we be testing for CKD? We're familiar with many of the common conditions associated with CKD, of course, type 1 and type 2 diabetes, but who else should we be offering testing using? eGFR, creatinine, and urinary ACR. Well, NICE give us a nice clear list here of a range of conditions that should prompt testing for CKD. As mentioned, those living with type 1 and type 2 diabetes, those living with hypertension, those who have suffered a previous episode of AKI, acute kidney injury. Importantly, AKI begets AKI. If you've had an episode of AKI, you're much more likely to suffer a further episode of AKI and much more likely to develop chronic kidney disease too. So any hospital discharge letters we get that have coded AKI, we should also code AKI in our primary care IT systems and ensure that individual is under recall for checking of eGFR, creatinine, and urinary ACR regularly. Anyone with structural renal tract disease, for example, hydronephrosis or recurrent renal stones or benign prostatic hypertrophy, we should also test for CKD. Any multi-system disease with renal involvement, for example, SLE or other rheumatological conditions. Those with a background of gout, those with a relevant family history of end-stage renal disease, or hereditary kidney disease, such as adult polycystic kidney disease. And finally, if you incidentally pick up any of your patients to have blood or protein in the urine, also do consider testing for CKD. So a whole range of conditions that we should consider checking for CKD. So how do we classify CKD? Well, one of the big updates to the NICE CKD guideline in the previous iteration in 2014 was to classify CKD by both stage of EGFR and also stage of albuminuria. And that's because declining EGFR and escalating levels of albumin in the urine independently predict the risk of adverse outcomes, both adverse renal outcomes but also adverse cardiovascular outcomes too. So for example, if you have a patient with an EGFR of say 45 and about 40 milligrams per millimole of albumin in the urine, they would have stage G3A, A2 CKD. And you can see, according to this slide here, for that person, they would be at high risk of future adverse outcomes of their CKD. So a very useful color chart here produced by KDIGO, one of the international chronic kidney disease organizations, to help us risk stratify those with CKD and to predict their risk of disease progression. And similarly, for that person with stage G3A, A2 CKD, how often should we be checking their bloods? How often should we be checking their EGFR and their urinary ACR? Again, we have a very helpful table produced here. So again, looking at someone with stage G3A, A2, at least once annually is adequate for that person living with CKD, stage G3A, A2. But as you can see, as that CKD becomes more progressive, as that stage of EGFR declines or the amount of urine goes up, we do need to check bloods and urinary ACR more frequently because of, again, that increased risk of adverse renal and cardiovascular outcomes. But as I alluded to at the beginning of this session, what the main focus of our management in primary care is how do we delay progression of CKD to try and avoid the need for renal replacement therapy. Well, of course, one of the staples of delaying the progression of CKD is to offer either an ACE inhibitor or an ARB to everyone living with CKD. But there's a little nuancing required here. For those with CKD and diabetes, as soon as that urinary ACR rises above 3, that is clinically meaningful albuminuria, and we need to be offering an ACE inhibitor or ARB. For those living with CKD and hypertension, as soon as that urinary ACR rises above 30, we should be offering an ACE inhibitor or ARB. And we should be offering an ACE inhibitor or ARB for anybody with CKD and urinary ACR above 70, irrespective of a background of hypertension, diabetes, cardiovascular disease. And importantly, we should be titrating up the dose of that ACE inhibitor or ARB to the maximum tolerated dose. We don't want to cause harm. Primum non nocere, our first principle of medicine, do no harm. So we don't want to cause postural hypotension, but we should titrate up to the maximum tolerated dose. In years gone by, it used to be trendy to combine ACE inhibitors and ARBs, but we know it's no longer recommended because of the high risk of acute kidney injury. So it's often causes a headache for us, doesn't it, in primary care when we start that ACE or ARB because of changes in renal function. So some useful pragmatic guidance here on what to do with that repeat renal function check. So as a reminder, after we start an ACE or an ARB, repeat the U&Es 1 to 2 weeks after initiation and after any dose increase as well. And importantly, if that baseline potassium is over 5, we shouldn't be starting an ACE inhibitor or ARB. Now, reassuringly, we can expect up to a 25% drop in EGFR after introduction of an ACE inhibitor or ARB, because this class of drug works by reducing interglomerular pressure. So it reduces blood flow through the glomerulus, through the kidney, and therefore you get a drop in EGFR. So we can expect up to a 25% reduction in EGFR. If it is more than this, then we do need to be a little bit more cautious about proceeding, but certainly about escalating doses. And again, depending on the extent of that drop, we may need to temporarily stop the drug as well, and perhaps look for other causes of underlying acute kidney injury or perhaps renal artery stenosis. So what about blood pressure targets then in people living with CKD? We all know tight blood pressure control can help reduce the progression of CKD. So what does the updated NICE guideline tell us about blood pressure targets? Well, again, reassuringly, they keep things very simple for us. For anyone living with CKD and urinary ACR less than 70, our target blood pressure should be a range of 120 to 139 systolic over less than 90. Individualized, of course, to that person sat in front of us, and take into account any significant comorbidities, of course, such as frailty. And for those living with CKD and a urinary ACR above 70, a tighter target range, if possible, again, individualized, of 120 to 129 millimeters of mercury systolic over less than 80. As I mentioned already, one size does not fit all. And as always, we need to individualize our approach to the management of CKD in primary care. Next, lipids. What does NICE tell us to do in terms of lipid or cholesterol lowering in the management of CKD? Well, I've told you already that CKD is in essence an independent cardiovascular risk factor. So a nice clear recommendation here. For anyone living with CKD, we should be offering atorvastatin 20 milligrams for the primary or secondary prevention of cardiovascular disease. What sort of lipid target should we be striving for? Well, in their CKD guideline, NICE actually signpost us to their lipid lowering guideline, which was published way back in 2014. But it does suggest, in the context of CKD, that we aim for a 40% reduction in non-HDL cholesterol. And if this is not achieved, we should try and step up the dose of the statin if the EGFR is over 30. If EGFR is below 30, we should probably phone a friend and discuss with our renal colleagues about the use of higher doses of statins. And that's because certain high-intensity statins can sometimes be associated with acute kidney injury. But key message here, we should be offering atorvastatin 20 for the primary or secondary prevention of cardiovascular disease in anyone with chronic kidney disease. And what about oral antiplatelets? I've told you a number of times, haven't I, that CKD is an independent cardiovascular risk factor. So it would make sense to offer antiplatelets, wouldn't it, such as aspirin or clopidogrel. So what does NICE NG203 CKD guideline recommend? Well, it suggests we only offer oral antiplatelets to adults with chronic kidney disease for secondary prevention of cardiovascular disease. And, as always, with anyone on an oral antiplatelet, we should be aware of the increased risk of bleeding. But this is particularly pertinent for people living with CKD. The jury's out for primary prevention of cardiovascular disease and CKD. We don't really have compelling evidence to offer aspirin or clopidogrel, for example. So at the moment, offer aspirin, clopidogrel for the secondary prevention of cardiovascular disease in anyone with CKD. So for anyone with CKD and a past atherosclerotic event, such as a myocardial infarction. And what about specifically people living with CKD and coexisting type 2 diabetes? What HbA1c should we be striving for? Again, this has caused considerable debate. We know from past seminal studies such as the UK PDS, the UK Prospective Diabetes Study, that tight glycemic control reduces the risk of microvascular disease, including retinal disease, neuropathy, and chronic kidney disease. But unfortunately, as I've suggested, there's been no real international consensus on what glycemic targets should be in people living with CKD. What we do know, though, is there's little evidence that very tight HbA1c targets, less than 53 millimoles per mole, or 7% in all money, reduces progression of CKD, especially in more significant forms of CKD, CKD stage G3 or worse. So again, very much consistent with our holistic management holistic management of type 2 diabetes, we should individualize HbA1c targets. One size does not fit all, and we should especially take into account context of the presence of significant comorbidities such as frailty, where we know that very tight HbA1c targets can of course worsen and cause harm. It should be pointed out, when looking at HbA1c in the context of CKD, be aware of the presence of iron deficient anemia. Very common, isn't it, alongside chronic kidney disease. Iron deficiency anemia may invalidate the HbA1c assay. So, in iron deficient anemia, your red blood cells live for longer, so they circulate for longer. So that means they're exposed to glucose for longer, so you get an artificially elevated HbA1c. Whereas in hemolytic anemias, after bleeding episodes, your red blood cells live for a shorter period of time. So they circulate for a shorter duration. They're exposed to sugar for a shorter duration. So you get an artificially low HbA1c. So just be aware, anemia may potentially invalidate HbA1c. So going on to some of the key new messages then in the updated NICE CKD guideline. As I said, further updated during November of 2021. Well, we were given, again, some clear messaging when to consider newer therapies to help reduce that progression of CKD. So for all our adults living with diabetes, if their urinary ACR is less than 3 milligrams per millimole, of course, we need to keep at least an annual eye on these individuals, monitoring their urinary ACR, monitoring their creatinine and EGFR, and also their blood pressure, and keeping into mind the targets we mentioned previously. But as soon as that urinary ACR rises above 3, that is clinically meaningful protein in the urine. So this is where, as discussed, we need to offer an ACE inhibitor, an ARB, and titrate that up to the maximum tolerated dose. But this is where things change for us in primary care, because if you've titrated and offered a maximally tolerated dose of ACE or ARB and the urinary ACR is still above 30, we should be now offering an SGLT2 inhibitor. But NICE takes things one step further again. If that urinary ACR is still between 3 and 30, NICE suggests we should also still consider an SGLT2 inhibitor. So you can see now, ladies and gentlemen, that SGLT2 inhibitors are now established as a new pillar of treatment to help reduce the progression of chronic kidney disease on top of standard of care. So on top of a maximally tolerated dose of ACE inhibitor or ARB. So big changes in practice for us in primary care. Of course, workload implications for us as well. But there's no doubt seminal trials such as the Credence trial looking at canagliflozin, the DAPA-CKD trial looking at dapagliflozin, and more recently the EMPA-Kidney trial looking at empagliflozin have all demonstrated a significant reduction in the progression of CKD and also reduction in death from cardiovascular and renal causes with SGLT2 inhibitors in people living with chronic kidney disease. And what's on the horizon? Well, many of you will be aware we are now using SGLT2 inhibitors even in people without diabetes. We've been doing that in the context of heart failure now for a couple of years nearly, and we'll be doing this for CKD as well. We had recently updated guidelines from the UK Kidney Association now recommending we consider the use of SGLT2 inhibitors in people without type 2 diabetes with a urinary ACR of over 25 milligrams per millimole. So watch this space, ladies and gentlemen. SGLT2 inhibitors are now established as a new pillar of treatment for the management of CKD in both people with and without diabetes. So finally, to finish up, when should we phone a friend? When should we consider referral to our renal colleagues? So there's a new recommendation here from our NICE CKD guideline. NICE now asks us to consider a renal risk equation called the KFRE, the kidney function renal risk equation. So what this calculates is the 5-year risk of our patients requiring renal replacement therapy. And if that's over 5%, we should consider referral to our renal colleagues. So this is what the calculator looks like. Very straightforward to use. We have to input our patient's gender, age, EGFR, urinary ACR, and their geographical location. And it calculates their 5% risk of requiring renal replacement therapy. And again, if that's a 5-year risk, and if that's over 5%, we should consider referral to our renal colleagues. NICE also list a range of other conditions or situations where we might need to consider referral. But ultimately, the best question to ask ourselves is that person sat in front of you likely to require renal replacement therapy within their lifetime? And of course, if the answer is yes, do have a low threshold to consider referring to our renal colleagues. However, if the answer is no, sadly, if your patient is frail with a guarded life expectancy, of course, we can take our foot off the pedal and take a more holistic approach to that individual, focusing on quality of life rather than quantity of life. And perhaps a renal referral is not required. So thanks everyone for listening. I hope you found this e-module on CKD helpful. Be sure to also watch the other programs in this series. We have a program on heart failure by Yasser Javed, a GP with a specialist interest in cardiology. And also we have a program on atrial fibrillation delivered by Beverly Bostock, a primary care nurse with a specialist interest in cardiovascular and metabolic medicine. Also, don't forget to register for our face-to-face conference in Birmingham, where we can put all this learning into practice, CKD, atrial fibrillation, and also heart failure, where we'll be discussing case studies in an interactive fashion.